my name is Amber Goana, and I would like to welcome you to my Med Talk. This is going to be some of the things I pulled from the CPJE California law exam, and as you can see, it's going to be basically like a little Naplex, and so each video is just going to go over each section that I kind of pulled little things from, and I hope you like it. For this section, we'll be going over medications that have an FDA approval for the use in the treatment of bipolar disorders. First up here is lithium. Lithobid is another name for it. It works by interfering with the synthesis, storage, release, and reuptake of monoamine neurotransmitters. It also enhances tryptophan reuptake, serotonin synthesis, and abdominal serotonin secretion. It's dosed 300 milligrams 3 times a day with a max of 2,400 milligrams a day. It does need renal adjustment. The trough level, you're kind of looking for 0.6 to 1.2 milliequivalents per liter. And you want to draw this level 4 to 5 days after starting the medication, and make sure it's 8 to 12 hours after their last dose. This medication is cleared 100% renally. It is known to cause hypothyroidism, blue-gray skin pigmentation, serotonin syndrome, and you want to avoid use with serotonergic agents. Some examples of medications that decrease lithium levels: theophylline, caffeine, acetazolamide, an increase in sodium intake, an increase in fluid intake, or loop diuretics all decrease lithium levels. Increased lithium levels, examples NSAIDs, thiazide diuretics, ACEs and ARBs. A decrease in sodium intake, dehydration, or diarrhea. Next we have valproic acid. Depakine is another name for it. This works by increasing GABA concentrations in the brain, and it also suppresses neuronal firing of voltage-sensitive sodium channels. The loading dose is 20 milligrams per kilogram, oral or IV, and then you want to do 10 to 15 milligrams per kilogram a day, with a max of 60 milligrams per kilogram a day. It's known to cause pancreatitis, thrombocytopenia, the DRESS syndrome, which is actually really life-threatening, and it affects multiple organs of the body. It can also cause sedation and QT prolongation, as well as increased ammonium levels and hepatotoxicity. It is 90% bound to protein, so having low albumin levels can cause an increase in valproic acid drug levels in your body. You want to avoid use in mental retardation or if the patient is pregnant. Some examples of things that can decrease in valproic acid levels: carbazepine, phenytoin, and rifampin. Increase in valproic acid levels: lamotrigine, zidovudine, and salicylates. Another medication that works very similar to valproic acid is divalproex. Depakote is another name for it. The last option I have here is carbazepine tegretol. This works by blocking the use-dependent sodium channel, reduces post-synaptic potential of synaptic transition in the spinal cord, and has anticholinergic SIADH, where it increases the release of that antidiuretic hormone ADH, as well as antiarrhythmic, muscle relaxant, antidepressive, sedative, and neuromuscular blocking properties. It is known to cause bone marrow suppression, the DRESS syndrome, just like valproic acid and Depakote, hyponatremia, hypothyroidism, which was just like lithium, dry mouth, and photosensitivity. You want to avoid use in allergic variant HLA-B 1502, which is usually seen in Asian ancestry people, as well as if they're taking MAOIs, you want to avoid. Also, liver impairment and pregnancy, avoid use in all those patients. General side effects of all these medications: they're going to cause weight gain and sedation. You want to monitor the patient's serum creatinine, BUN levels, as well as their liver function tests, their CBC in general with their differential, as well as their electrolytes. So for patients who are experiencing a mania bipolar episode, their recommended treatment is going to be lithium or valproic acid plus a second generation antipsychotic like olanzapine, risperidone, or quetiapine. In patients who are expressing depression, you want to be treating them with lithium, lamotrigine, or quetiapine, either one of those three. Lorazepam and Symbiox are also approved by the FDA for acute bipolar depression, but they're not really the preferred agents. Maintenance, you want to treat them with lithium plus or minus a second generation antipsychotic, or lamotrigine if the patient mainly expresses depression symptoms whenever they have an episode of bipolar, or valproic acid for the mania, for bipolar mania, as well as carbazepine could also be used for bipolar mania. If your patient is pregnant, you want to be using lamotrigine or a second generation antipsychotic, or lorazepam, really if the patient's got that depression type symptom. Some examples of the second generation antipsychotics used, mainly you got aripiprazole, Abilify, lorazepam, Latuda, olanzapine, Zyprexa, quetiapine, Seroquel, risperidone, risperidone. But there's also ziprasidone, Geodone, Symbiox, which is a combination of olanzapine and fluoxetine, aspirinine, which is Zyprexa, and carpezine, which is Vylar. And Vylar is actually a new approved drug for treating schizophrenia and acute manic or mixed episodes associated with bipolar 1 disorders. And that is all the drugs they had listed that had FDA approval for the use in bipolar disorder. Again, my name is Amber Gawana, and I wish you the absolute best of luck in all your studies.